Excellent. Well, I would like to just briefly go over and say thank you guys for joining. My name is Kyle Brown. I am one of the officers for the Southeast chapter of SCCM. Before I begin, I'll just quickly go over our presenters. Today we have Dr. Ryan Grant. He is a board certified critical care pharmacist in trauma. After earning his doctorate of pharmacy from the University of Louisiana Monroe College of Pharmacy, he pursued 2 years of postgraduate training in critical care pharmacotherapy at Methodist Dallas Medical Center in Dallas, Texas, where he learned his true love for trauma critical care. He works alongside a wonderful team at LSU Healthcare Shreveport to help create the best patient outcomes possible. He has multiple interests within the world of critical care medicine, but he is especially passionate about the topic today, which is VTE prophylaxis for critically injured trauma patients. Next, we have Dr. Victoria Cuebas-Hiner. Dr. Cuebas-Hiner is a recent graduate from the general surgery residency at McCormick-Macomb Hospital in Mount Clemens, Michigan. She completed her medical school at Marian University College of Osteopathic Medicine in Indianapolis, Indiana. She completed a Master of Science in Physiology at Ball State University in Muncie, Indiana, where she also received her Bachelor of Science in Biology and Pre-Medicine, with minors in Chemistry, Physiology, Spanish, and Leadership Studies. Dr. Cuevas-Hiner also enjoys spending time with her husband, Jordan, and her dogs, Enzo and Gus, and is an avid outdoors woman. She plans to pursue a career in trauma acute care surgery and surgical ICU upon completion of her fellowship. Next, we have Dr. Matthew Chung. Unfortunately, he was not able to join us today, but he is a graduate from La Jolla Strict School of Medicine and completed his general surgery training at La Jolla University Medical Center. When he is not at the hospital, he is enjoying cycling, running, and photography. And then finally, we have Dr. Taylor Conrad. He is an assistant professor of medicine at LSU Health Shreveport, specializing in critical care medicine and emergency medicine. He completed his training in emergency medicine, internal medicine, and critical care at sunny Downstate in Brooklyn, New York. Dr. Conrad serves as an associate program director for the Critical Care Fellowship and director of telecritical care services. His interests include ECMO, critical care ultrasound, disaster preparedness, CRRT, septic shock, and ARDS. Thank you again for everyone joining us today, and we look forward to the spirited discussion after our wonderful presentation. Thank you.
All right. So good afternoon, everybody, and thank you so much for that wonderful introduction for us. Hopefully everybody should be able to see my screen at this point. So I just wanted to give a brief introduction, and then I'll break it right off to Ryan to talk about venous thromboembolism. So ultimately, overview, we're going to kind of go into the small bites of venous thromboembolism and VTE prophylaxis, which I think is quite a big topic, and Ryan is doing an amazing job of kind of summing all of that up for us. I will talk about anticoagulation of reversal, which is what Matthew has contributed significantly as much, and Tori's going to go through some TEG with that. Before we moved on, I just wanted to do one slide to kind of frame us a little bit as we talk about some key important factors in management, understanding, and prognostication in trauma and anticoagulant effects, is that there's a growing area of research occurring in trying to understand the hemostatic effects of severe trauma. So we're talking about the polytrauma, multi-system injury, TBI, very severe patients, and I want you to just kind of pay attention to that group and note that as we start to understand this field a little bit more, it starts to kind of make a little bit more sense, at least to me, in kind of framing where we get these risk factors for thromboembolism, the outcomes, the bleeding, the hemostatic disease, and coagulopathies associated. And of course, we've got enough to talk about with all of the different medications that are currently out there as well. So that's enough of me. I'll go ahead and move it on to Ryan, and I'll get back on my section in a minute. And I think you're still muted, Ryan. Yeah.
Perfect. Thanks for the heads up. We're going to start off with VTE prophylaxis in trauma patients, which, as we're going to get into, is going to be really nuanced and patient specific. It's one of the really interesting things that keeps trauma exciting for me. So let's see if we can advance the slide. So Dr. Conrad alluded to that there is, I guess, a trauma-induced coagulopathy that can occur after a patient's traumatic injury. And the hardest thing to determine at any set point is which phenotype that the patient is going to belong to. You're going to have patients that may present with a more hypercoagulable phenotype, where you're having an increased thrombin generation, hyperfibrinogenemia with platelet activation, and then fibrinolysis shutdown. And that can contribute to a more thrombotic phenotype. Patients will also experience a bit of a bleeding phenotype, where hyperfibrinolysis, platelet dysfunction, fibrinogen depletion, and then decreased thrombin generation play into risk factors that would contribute to more bleeding and thrombosis. But more oftentimes than not, our patients are fluxing between the two at any degree and having some form of a mixed phenotype. So what we're getting reinforcing here is that patients can be at risk for thrombosis while also being at risk for bleeding at the same time. So having appropriate and poignant discussions around when to begin VT prophylaxis is critical for the care of trauma patients. So VT risk within high-risk trauma patients is about, or estimated to be, greater than 50%, with pulmonary embolism rates estimated between 1.5% to up to 20%, depending on the population. Whereas early appropriate chemoprophylaxis has been shown to decrease the VT risk to only about 5%. And the majority of these VTE events have been shown to happen within the first weeks of hospitalization. However, we have current literature showing that they can happen as soon as 48 hours. And this study is one of the studies that reinforces that concept. So what this study group looked at was just the time with which patients developed any sort of venous thrombus, whether it be a deep venous thrombus or a pulmonary emboli, from day of hospitalization. And you can see there's a rather large spike in the incidence and detection of venous thrombi, even within that first week of stay, but even for PEs within the first 4 days of admission. So appropriate use of venous thromboprophylaxis has been shown to mitigate this, as we discussed in the previous slide. They found that the odds ratio for delay of development or delay of initiation of VT prophylaxis between 24 to 48 hours increased the risks of our patients developing a clot by 26%, and then waiting beyond 48 hours and increased the risk twofold. So these are very, very important decisions for us as providers to have and balance for our patients. So let's get into who is at risk. There was a study back in the 1990s that looked at identifying the various patient phenotypes and criteria that would show who is at the highest risk for developing thromboemboli. And so what this study showed was that patients that have a traumatic brain injury, spinal cord injury, pelvic fractures, any lower extremity fractures, or patients undergoing major venous repair. And this, I guess, scoring criteria is generally known as the RAP score, the RAP-T score. And you see the breakdown on the right side of the screen right now. It has various, I would say, patient characteristics, and then the risks that are associated with them from a point-wise standing. And then you have your low risk, your moderate risk, and then your high risk. Anybody that is not at low risk and would be, I guess, a score of 5 or greater is an appropriate candidate for VT prophylaxis and should be at the highest, I guess, consideration for prompt initiation as able. And you can see that back when this study looked at stratifying the risk between those phenotypes, you see moderate and high have a much higher incidence of venous thrombus than our low risk profile. So anybody, again, who's TBI, spinal cord injury, pelvic fractures, lower extremity fractures, or major venous repair are the ones that really flag my radar as patients who really should be initiated on VT prophylaxis as soon as able. Now, what agent should we use for VTE prophylaxis? Where the trauma and acute care surgery guidelines actually recommend enoxaparin as the first choice for VTE prophylaxis and identify it as the standard of care. So that is a really important point to reinforce, that enoxaparin is our standard of care for VTE prophylaxis for these patients. The standard dosing that the American College of Trauma recommends is generally 40 milligrams twice daily, which is roughly about half a milligram per kilogram per somebody's total body weight. They actually recommend reducing to 30 milligrams twice daily for anybody who's over 65, traumatic brain injury, spinal cord injury, or pregnant patients. And then ESRD patients should still receive unfractionated heparin per institutional policies. The American College of Trauma also recommends to not delay the initiation of prophylaxis just for low platelet counts. Less than 100 to greater than 50,000, we're still well within the reason to initiate VTE prophylaxis. So relative trauma thrombocytopenia, especially within the first 48 hours as we're undergoing resuscitation, patients are getting blood products, is not an appropriate reason to delay the initiation of VTE prophylaxis. Now, they also recommend to target initial peak levels, basically, for anti-10A activity. Now, I'm not sure how many hospitals have the capacity to do this, but here at Ochsner and Shreveport, we're actually very fortunate we can run anti-10A assays. And so our protocol is generally to target a peak level of about 0.2 to 0.4 international units per ml for anti-10A activity after Lovenox dosing. So we're trying to target a peak anti-10A activity between 0.2 to 0.4. So right underneath that kind of prophylaxis and or like therapeutic window, because generally that's going to be 0.3 to 0.7-ish for Lovenox. And then we increase the initial enoxaparin dose generally for obesity, and then BMI is greater than 30. They actually recommend, the guidelines recommend to be dosing at least a half a mg per kg twice daily, as able to with appropriate renal function adjustments. So just a glance over what our policy looks like. So we have patients that meet the policy, and then we have that basically weight stratified. So we do a little bit different than what the trauma guidelines recommend, but we do a true about half a mg per kg twice daily with a cap at 60 milligrams twice daily for patients that are over 120 kilograms. Now, that cap can definitely be exceeded if the team feels as though the risk for VTE mitigates a higher dose of enoxaparin. And we've done that on several occasions. I made the recommendation on rounds today to do a little higher dose for somebody as well. And then once we get to our end-stage renal disease or our impaired kidney function, be it acute or chronic, we basically go down to our 30 milligrams twice daily. And then even for hemodialysis, we're actually very aggressive here. We'll still use enoxaparin in those patients as well. And then our protocol, as we discussed, is trying to target a peak anti-10A activity of 0.2 to 0.4. So what we do is we will at least let 3 doses of enoxaparin go to try to get to where you're at steady state, and then grab peak 10A level, which is about 4-ish hours after the enoxaparin dose is given. And we're trying to target that level. And if it's not within that level, we'll make adjustments up or down in increments of about 10 milligrams per dose, and then recheck, rinse and repeat. So it's pretty standard, and we have lots of really, really good outcomes doing this. So we've discussed who's at risk and what we're going to use to prevent the risk, but now I think the biggest question is when to begin prophylaxis. So luckily, we don't have to reinvent the wheel, and that the American College of Trauma and Acute Care Surgery has an excellent algorithm dictating when VTE prophylaxis should be given. And the science behind all of this is based off of really robust meta-analyses that show that this strategy is as safe as daily Lovenox, and or safer and more effective than heparin doses. So the initial decision point is, does the patient who is a trauma patient have any sort of a high-risk injury? That being a TBI, spinal cord injury, solid organ injury, or if they're undergoing, or if they're still actively hemorrhaging. And if the answer to any of those things is yes, then you go on to the left side of this algorithm. And if it's a TBI, you're going to use the modified Byrne-Norwood criteria to dictate when timing VT prophylaxis should begin. And we'll cover that in the next slide. If the answer to that is no, they don't have a TBI, but yes, they have a spinal cord injury, that generally recommends to initiate prophylaxis within 48 hours. Now, we're going to have conversations with our neurosurgeons or orthopedic surgeons about when we're going to be able to do that, because these patients will typically go for spinal stabilization within that first 48 hours for our critically ill patients and most injured patients. So we have to have that conversation about when can we provide this evidence-based prophylaxis, hopefully within the first 48 hours. And then if they don't have a spinal cord injury, but they have a solid organ injury, we're basically looking for signs of ongoing hemorrhage. And so we'll typically monitor that through serial hemoglobins or hemodynamic values at the bedside. These patients are going to be admitted to your ICU. You're going to see hemodynamic changes well before they have an acute blood loss, as reflected by hemoglobin trends. And so if the answer to that is they have signs of ongoing hemorrhage, we're just going to continue to provide mechanical prophylaxis. But we're reassessing these variables daily to make sure that we're going to continue to have that conversation as to when can we provide the prophylaxis. If they don't have any of those high-risk injuries, then you're starting prophylaxis immediately. And then it dictates, what dose on the right side of the screen. So in general, it's within the first 24 hours. But for TBIs, it's very specific. So this is the review of the modified Byrne-Norwood criteria, and it stratifies patients into low, moderate, and high-risk patients. So the low risk is basically anybody who doesn't have a high or moderate risk finding. Moderate risk is anybody that has a subdural or an epidural hematoma of significant size, say 8 millimeters, some contusions or intraventricular hemorrhages that are greater than 2 centimeters, multiple contusions within a single lobe, subarachnoid hemorrhage with abnormal CT angiogram, or then evidence of progression at 24 hours. If any of those signs are present either initially on the scans or evidence of progression at 24 hours, then you're going to begin prophylaxis within the first 72 hours after your stable CT head. And for the highest risk patients, and that's basically patients that have an ICP monitor placed or go for emergent craniotomy or evidence of progression even at 72 hours, you're going to just continue the screening duplex or IVC filters. We don't personally do that here at Ochsner. We just continue to have the risk mitigation strategies that we've talked about, SCDs. We have one of our trauma attendings who will actually do maybe a little lower dose of the enoxaparin up front, just to have something on board. And we have not seen any adverse outcomes from that strategy just yet. So again, to reinforce, the appropriate time to begin VT prophylaxis for any trauma patients is generally within the first 24 to 48 hours, definitely within the first 24 hours if able, as we know that prolonged delay in initiating VT prophylaxis markedly increases a patient's risk for venous thrombus, which is going to potentially increase their mortality, but definitely will increase their morbidity. The final thing that I want to leave everybody with is just how long do we provide VTE prophylaxis? How long does this trauma-induced coagulopathy really hang around? And really what's recommended is for any sort of spinal cord injury with a lower extremity deficit, you're going to continue prophylaxis at least 3 months after the injury. If they don't have a spinal cord injury, but they have any sort of a pelvic fracture, lower extremity fracture, and they have limited mobility, you're going to then ask yourself if they have a TBI. The answer is yes, then you're going to continue for at least 28 days post-injury. And you can do the enoxaparin dosing that we've discussed. If they don't have a TBI, you're still going to continue for 28 days post-injury, but you're going to drop to aspirin, 81 milligrams, which is a much more affordable option for the majority of our patients. And then if they don't have a spinal cord injury or any lower extremity fractures with limited mobility and a traumatic brain injury, then you don't really need to continue prophylaxis beyond hospital discharge. So just in summary, I want to reinforce that trauma patients are at very high risk of potentially mitigatable VTE, and the RAPT score has been best suited for identifying those at risk of VTE. If you can't do the RAP score, then the Caprini score actually performs pretty similarly, but I just think of those 4 criteria: TBI, spinal cord injury, pelvic fractures, lower extremity fractures, and then venous repair. If they have any one of those, then they're going to be at high risk, just in general. VTE prophylaxis should begin within 24 hours of admission generally, with some exceptions being the TBI, you're going to follow the modified Byrne-Norwood criteria. Spinal cord injury, it's generally going to be a conversation with your surgeons, and then solid organ injury with ongoing signs of hemorrhage. And then if your institution is able, the standard of care really should be to target peak 10A levels between 0.2 and 0.4.
Wonderful. All right, 1 second. Make sure I have the correct screen. Okay. Oop. Sorry about that. It's having a little delay, I apologize. Okay. All right. Sorry about that. All right. Good deal. Okay, good. All right. So apologize for that brief interruption between that amazing introduction to thromboembolism. And we're going to transition now to talk about reversal of oral anticoagulation. And I think this is a topic that's going to increase more, especially as we have an increasing elderly population, increasing comorbidities, increasing agents, really, and there are increasing diagnoses in which we're seeing benefit either from secondary prophylaxis or prevention or management from complications at that point. And so, it's not quite working. There we go. And so what type of, there we go. Okay. So what type of oral anticoagulants do we commonly see? So when I started my training, I was still in the era just before the oral agents were coming in other than Coumadin. And so fortunately now we don't see that as much, but there are still certain patient populations have been well managed on that. And so we will oftentimes still see that, but we've seen increasing utilization of other anticoagulants across many different disease paradigms and subspecialties as well. It's important to remember that, of course, Coumadin is going to inhibit not just our anticoagulant or our coagulant factors, but also it inhibits our procoagulants. And that tends to really only come into issues in specific scenarios. And since we don't utilize that as much anymore, we won't worry as much about that, but we'll talk about more about the reversal agents for each in a little bit as well. Factor 10A inhibitors, of course, we have our reversible direct inhibitors of factor 10A and include several different ones and some newer ones that are on the market with varying different dosing strategies and a little bit pharmacokinetics from that. We also have our oral direct thrombin inhibitor, dabigatran, which is a direct competitive inhibitor of thrombin and has its own specific reversal agent as an antibody, which we'll talk about in a little bit as well. And so what are our reversal agents? And so one of the big ones and kind of the primary ones, especially in significant trauma, major bleeding on our patients who are on the more common oral anticoagulants, and for patients who are essentially on Coumadin as well too. And so at this point, primarily brand names you can see are Kcentra, Valfaxar, Bariplex, and we are actually just replacing all of these factor at a significant higher concentration than you would normally find in fresh frozen plasma. And we'll talk about that in a little bit as well. There has been studies that kind of show utilizing FFP versus PCC in undergoing emergent or emergent procedures. And so it was non-inferior regards and superior to hemostasis in regards to fluid overload and cardiac events, and we'll talk about that in a minute. But it's really the volume that is the issue, and that's corrected with this combination of concentrated factors. And so what is the dosing for that? Typically a 1500 single unit dose or weight-based dosing with the max up. I almost always involve our pharmacists, which we're fortunate to have here, in dosing one, and it can be variable, especially at the extremes of weight, and if we don't quite have labs, especially in an emergent kind of rush roll situation. We do have other tests that we can talk about a little bit later about that as well. So what are some other factors? So it's not just Kcentra that's actually on the market. There are 3 factor PCCs that are out there as well. And so as you can tell, it doesn't include any of the procoagulant aspects as well, but primarily includes factors 2, 9, 10, and low levels of 7. And so primarily it's approved for hemophilia B. Generally, when we kind of compare it in utilizing 4-factor, we're going to have a little bit better reversal more frequently with the 4-factor, and that I believe is in most trauma centers tends to be more common availability at that point. There's also activated PCC, which is currently FDA approved for hemophilia A and B, but is not currently have an indication specifically as a reversal agent for any agents at that point. And so going back to our classics, right, FFP, where we ultimately derive a lot of those other factor concentrates from as a concept. And so this is generally what we would utilize if we don't have any of these concentrated areas available. It does have dosing kind of appropriate for us, which would be about 10 to 15 mLs per kg, but certainly volume becomes a problem, especially when we're talking about some of the amounts required for some of the oral agents, or if someone has a significant overdose, even on a vitamin K antagonist as well do. And so it's associated with longer time, administration, larger volume, and while we may not necessarily have specific data to look at what is this mortality difference between these two, I think we do know that a lot of morbidity and possibly mortality it tends to certainly increase with our delay in getting either hemostasis, source control, which can come from delays of complications of resuscitation down the line. So we'll talk about one of the newer ones that's now on the market, Andexanet Alpha. I was kind of coming around when I was in initially medical school as well. It's an inactive recombinant protein that's similar to factor 10A. Competitively, it binds the inhibitors. And so when the dosing is known, there could be a lower dose that's utilized. The medication does have a little higher price tag associated with it than some of the other agents that we've talked about on the market. And when the dose is unknown, kind of a more empiric higher coverage dose is utilized from that. We do have some trials. We'll talk about the Annexa 4 trial briefly, and I'll talk about the Annexa 1 trial on the next page a little bit more. I mean, it is an effective drug in reducing the reversal of apixaban and rivaroxaban. And I think to kind of point out a little bit more, and we compare PCC in Andexanet Alpha, some of the data that we have from the New England trial, the Annexa 1 trial, looked at usual care, which included PCC primarily, but not only PCC, and the Andexanet Alpha reversal for intracranial hemorrhage. And it certainly was able to show, I think, some important clinical findings, which were hematoma volume change, NIHS score change. But one of the biggest, I think, concerns that I have about this is that it's a grouping of a bunch of different outcomes, some of which are significant and some of which are not. And so the NIHS score wasn't actually that significant and even contributing to this combined combination score. And I think that most of us, when we talk about reversal agents, really care the most about the end goal and the recovery on that. And so while it did certainly improve the reversal specific for those types of agents and have a little bit better reduction in some of the secondary measures, I think it also comes with the risk of increased stroke and increased thrombotic events as well. And so I think that, at least from my interpretation, a little bit more information is kind of needed in comparing that in determination of, what should be kind of the primary treatment. We'll talk about what the society recommendations and guidelines are in a second. Lastly, we'll talk about Praxbind, idurucizumab. I think I got that right. This is a humanized monoclonal that is specifically for binding the reversal only of dabigatran. So it's specifically made for that. That's why it's called Praxbind. And ultimately, it's just a single dose vial. I've used it. It does work. Unfortunately, I think that it's an excellent, direct thrombin inhibitors are excellent anticoagulants. And so unless it's caught incredibly, incredibly early, some of the damage may be done. The reverse AD trial was established in it, and so it is an incredibly effective drug if it's available, and it is what I would prioritize for utilization and reversal in severe bleeding that cannot be controlled or some necessary bleeding when Pradaxa is involved. And so what do our current algorithms and society recommendations, especially kind of from the trauma aspect and from the alternative side, the General College of Cardiology. And so ultimately, the recommendations, if it's a vitamin K antagonist, we're going to go straight to PCC. And this is kind of where I wanted to point out one of the pearls and pitfalls that come with reversing Coumadin that I sometimes see is you should ultimately kind of give some vitamin K depending on the situation and the dose. If there was an overdose that's situated and it's related to that, there can be some alterations in factors if vitamin K is not replaced as well, and you can actually see some rebound. And so one of the other societies, the Journal of American College of Cardiology, for vitamin K antagonists essentially is similar in that respect as well too, without direct mention of the vitamin K antagonists. Direct thrombin inhibitors, I think most people generally agree. Praxbind, if it's available. PCC, which will replace some factors and provide some, and hemodialysis can be considered because it is able to be removed via dialysis because of how small a molecule it is. And so when we look at the American College of Cardiology, I'm pretty much in agreement there with even an additional argument that if it was a recent ingestion, it might even be worth it to go ahead and consider charcoal or other aspects because of, again, how effective these direct thrombin inhibitors are and difficult they can be to reverse in this oral form. Factor Xa inhibitors, and so the guidelines are still recommended either PCC or andexanet. The American College of Cardiology is going to prioritize andexanet for now, but if not available, PCC or activated PCC. And they also recommend consideration of reversal of the oral agent depending on the ingestion time. And so one of the last things I didn't specifically talk about, since we were talking about Lovenox, I just wanted to throw in, of course, we do have a reversal specific to that. It's going to be weight-based dosed and dosed based on the amount of Lovenox that was given. But ultimately, we're having an increasing rate of utilization of these due to, one, the aging population and also probably multiple other factors. And so I think that we're seeing an increased need to kind of balance the challenge between these patients' need for anticoagulation as well as their potential complications associated with acute trauma. And with that, we can move on. Thank you.
Okay, hopefully everyone can see my screen here. So I'm going to talk about thromboelastography, or TEG, in trauma. Oh, it's not letting me move slides. I'll go down here. Okay. All right, so I think this picture, I'm not going to belabor this. It's something that we've all probably seen and memorized and forgotten many of times. Some may have some PTSD from that. But really the main reason to have this here is just to show that the coagulation cascade has lots of different factors, which we all know. And TEG can look at different parts of this. So looking mostly at the intrinsic pathway, you can see R time here, which we'll talk about a little bit more later as well, the K and alpha angle here, and then the MA or clot strength, and then the clot breakdown. I think there's a little delay. Okay. So for trauma, I think we've all seen the lethal triad, which has recently been updated to the diamond of death to include calcium. So not necessarily the part of our talk, but coagulopathy obviously is a part of that. So TEG can be used to help stop the worsening of that coagulopathy. So we'll be looking at that in a little bit more detail. So, you know, trauma is one of the leading causes of death, especially in ages 1 to 46. It's the #1 cause of death. And of that, 35% of those deaths are caused by hemorrhage. So that's the leading cause of preventable death in trauma. So if we can prevent that hemorrhage or slow it down, that's obviously better. And the median time frame from hemorrhagic shock to death is only 2 hours. So really time is of the essence. So having something that is real time to help us better resuscitate our patients is what we're looking for. So that's something that TEG will give. So it's a real time analysis. So you can see this actual tracing, real time logging in to better resuscitate your patients. So here you're seeing the TEG tracing itself. So you see the R time. So that's really looking at once the damage has happened to those vessels. So you get the damaged blood vessels, you have the clotting factors coming into play, prothrombin going to thrombin, and then fibrinogen going to fibrin to make that platelet plug and cross-link it. So this shows all of those real time, kind of as you see on the picture here, the R time going up to the clot strength and then the clot breaking down as well. So those are multiple different areas that you can target in your resuscitation. So the specifics of TEG, each of those, you have different tracings that run simultaneously. So again, you can see those mappings as they run. So the basics of it, it uses kaolin, which is one of the activators of clotting, and other reagents mixed in to test different things. So the kaolin TEG is the CK. So the kaolin activates the intrinsic pathway, so it measures that. So obviously the intrinsic pathway has multiple different factors, prothrombin, thrombin, things that we saw in that picture at the very beginning. The kaolin plus heparinase has the answer to one of two questions. Is there heparin in the patient? And how well would the blood clot if heparin wasn't on board? So this essentially takes the heparin out of the equation to let you know how effective the heparin is and what the blood would be doing without the heparin. The rapid TEG or the CRT uses a tissue factor in addition to the kaolin. So this also measures the extrinsic pathway to have less factors involved. But again, the intrinsic pathway is the majority of TEG. So this one is a lot faster. It can be completed entirely within 15 minutes, but it does not work well for detecting warfarin. So that's something that you would still want to use INR to detect. Next, the TEG functional fibrinogen is including platelet inhibitors. So this tells us if the patient has a low MA, they might need platelets or cryoprecipitate. So when you're looking at these different tests, if they have a low MA on the CK or the CRT, so the kind of traditional TEG, and the CFF, you would give fibrinogen. And if they have a low MA on the CK and not on the CFF, you would give platelets. So this is because the platelets contribute to approximately 80% of the MA. So a low MA on the standard TEG indicates poor platelet function, while the CFF tests provides a way to see how much of that strength is secondary to the fibrinogen. And again, coming back to this picture now that we've talked about some of these things. So looking at the R time, so that's the first part. So that's looking to see how fast the initiation of the clot is. So how long does it take for the clot to start? So if that is too long, so if it's taking longer than normal for the clot to be formed, you'd give FFP. So again, you're providing those coagulation factors that are needed to help form that clot. Next, you have the K time. and the alpha angle, which are both looking at the rate in which the clot forms and the time it takes to get to the strength, the maximum strength of the clot. So if that is, the K time is too long or the angle is too shallow, then you would give cryoprecipitate. Again, that's giving fibrinogen factors 8, 13, von Willebrand factor, and fibronectin. And then we talked about the MA. So that's the maximal amplitude of that portion of TEG, and that's looking at the strength of the clot. So looking at the platelet and fibrin interaction to see how strong the clot is. So if that is low or too kind of short, the platelet and fibrin isn't strong enough, so you would give more platelets to help strengthen that clot. And then the last part of this is the LY30, so that's lysis. It's the amount of lysis over 30 minutes. So if the body is breaking down the clots too quickly, you would need to give either tranexamic acid or aminocaproic acid to help slow that clot lysis down. And then this is just another picture. It's kind of busy, but it really puts all of that in the principles of TEG. And then there are a lot of different TEG tracings that you can see here, and it kind of tells you what is wrong with them. So obviously you'll get a number associated with these TEG results, but sometimes when you look at the tracing of it itself, you can kind of tell just by looking at what might be wrong. So the top is showing normal. And you can see below that is the anticoagulants or factor deficiency. So again, you're seeing that prolonged R time. The MA is a lot shorter or decreased than normal. And you'll have a prolonged K and a decreased alpha angle as well. So we just heard about all the different reversals and things like that if you do have anticoagulants on board, but this will also show you a kind of pictorial of that. There is a separate TEG that is platelet mapping, which can show you the effects of platelet inhibitors such as clopidogrel and aspirin. That is a little bit different than the ones that we're talking about, but either way, you can see the platelet blockers here are going to decrease that MA, again, stating that you might need to give platelets or potentially DDAVP. And then again, fibrinolysis, so the clot has been formed, but then it broke down too quickly. So you're seeing an increased LY30 and the decreased MA as well. And then DIC has different findings early and late. I won't get into the details of that because it's pretty specific. So TEG-guided resuscitation protocols, the advantages of this, you're able to see quickly, real time. So the R time is within 5 minutes, the MA and alpha angles within 15 minutes, and the LY30 takes 45 minutes. So you're able to see how well the clot is forming and how strong it is pretty quickly to be able to guide your resuscitation with those factors that you might need. So again, if you have a prolonged R time, you would need to give FFP. If you have a decreased alpha angle or a long K time, you would give cryoprecipitate. Decreased MA, you would give platelets and consider DDAVP. And then fibrinolysis, you would give TXA or the aminocaproic acid. And then I like this picture personally. It's kind of, again, wrapping all of that up into a nice picture and color coded. So again, shows you the components of the TEG color coded here, seeing what the problem might be, coagulation factors, treatment, FFP, and that sort of thing. So same information, just a different way to look at it. So now going into some studies to show us why TEG is important. So Gonzalez et al. Actually did a randomized clinical trial looking at viscoelastic assays, so essentially TEG, ROTEM versus conventional coagulation assays. So that's INR, fibrinogen, platelet count. And they found that using TEG to guide massive transfusion improved survival compared to conventional assays. So they looked at 111 patients randomized into a TEG versus conventional assay groups to guide the therapy, and the primary outcome was 28-day survival. And this was analyzed, 34.6% mortality was seen in the conventional methods versus 19.6% in the TEG therapy. Next, East did publish a practice management guideline conditionally recommending using TEG-guided transfusions over conventional assays in adult trauma and surgical patients and patients with critical illness. So within this, they found that TEG or ROTEM-guided transfusions in the acutely bleeding trauma patient, surgical patient, and critically ill was associated with fewer blood product transfusions in all of those populations. It was also associated with a reduced number of additional invasive measures, whether that be angioembolization, endoscopic intervention or surgical intervention in surgical patients. And lastly, it was also associated with a reduction in mortality in trauma patients specifically. And finally, Whitting et al. Looked at the viscoelastic testing to assist with diagnosis, looking to see the cost effectiveness as well. So this was 39 publications, looking mostly with cardiac surgery patients and trauma patients. And it also showed a reduction in red blood cell, platelet, and plasma transfusions. They didn't find a significant difference between these groups with other blood product transfusions, and the clinical outcomes weren't significantly different either. But in conclusion, TEG is a valuable, dynamic, and real-time evaluation of coagulopathy and clot functionality. So this can be used to better guide your resuscitation in a bleeding patient. So TEG should also be repeated, whether that's after you've given a resuscitation blood product, or if there's been an acute change in the patient, you can repeat this multiple times as needed to help further guide your resuscitation to see if there's any other transfusion needs that the patient might have. So this can be used to reduce the number of transfusions given, along with potentially reducing the invasive measures that might need to be given to the patient if they aren't properly resuscitated, and it can reduce mortality in trauma patients. I'm happy to answer any questions if anyone has them.
All right, thank you, everybody. When you guys get a chance, feel free to put the questions into the chat. I do have one. I know based off of your experience, Dr. Conrad, with use of ECMO, do you guys see any kind of impact with mechanical circulatory support interfering with bleeding risk? And how does that play into using, let's say, TEG for management?
Dr. Conrad, you're muted.
How about now? There we go. So we do actually utilize TEG both in our trauma resuscitations, but also in the ECMO patient and the patient who has trauma and is on ECMO. But primarily we utilize it to kind of get a baseline or any resuscitative aspects really in a similar manner. That is actually really a growth area, and that's actually an area where we don't have a lot of hard data. The ELSO registry has started to put together some publications and experiences against different trauma centers and trying to kind of understand. I haven't quite seen that outcome, but at least from our institutional experience, we have had situations in which we don't utilize anticoagulation because of ongoing bleeding or other active concern from our surgical services at that point. And there are times in which we feel that there's one of the interesting aspects, and that's kind of where I was getting in with the endotheliopathy part, is that there's also some times in which they can kind of go into DIC with the contribution of the ECMO circuit if we're not giving anticoagulation. And so I think that is kind of where our science is catching up exactly with kind of our understanding. And I think we've seen cases in which I have continued anticoagulation through significant trauma, but usually only if we have kind of source control and initial stabilization. But if there's concerns for active bleeding, we withhold anticoagulation, whether it's a traumatic event or not, at least for as short as we can.
Excellent, thank you so much. Is there any other questions in the chat? If not, I want to say thank you again to our speakers for taking the time. We really appreciate the information and learning a little bit about anticoagulation initiation as well as management in the trauma ICU. So thank you again. And please be on the lookout for an upcoming list of bite-sized lectures to come in 2026. Thank you, everybody. Goodbye.
Thank you.